should be seen. If you are able to see it, yeah, it's seen. Yes,
Yeah. Okay.
we are live now. We'll begin.
Okay.
So,
Okay.
good evening, viewers. Today we have with a new speaker. He's Dr. Amit Sridharan. He's a very good friend of mine. He's practicing at Aster MIMS, Kannur, Kerala. He's a consultant pulmonologist and critical care medicine, and he'll be with us discussing about ventilator-associated pneumonia. We welcome you, Dr. Amit. We are very glad with the busy schedules of too many COVID patients in Kerala. You are there with us with this webinar, and we welcome you. And you can begin the webinar now.
Thank you so much, Dr. Puneet. We have had a long friendship actually, starting, I think it might be more than 12 years now. Uh, anyway, thanks to the Karnataka Pulmonology Association, KPA, for giving me an opportunity to present on ventilator-associated pneumonia. I'm Dr. Amit, and I work as a consultant in pulmonary and critical care medicine, devoting 90% of my time to intensive care unit, uh, and have my interests in respiratory critical care and infectious diseases. And I think without wasting much time, I would go to the topic proper, that is ventilator-associated pneumonia. So going to the definition part, uh, it develops in intensive care unit patients, ICU patients who have been mechanically ventilated for at least 48 hours, and usually has got signs of respiratory infection with radiographic infiltrates in a patient who has been ventilated for at least 48 hours. So that is VAP, and there is something called as VAT, which is also part of the, it's a continuum actually. So there is VAT first, and then usually VAP happens. So in the ventilator-associated tracheobronchitis, there is signs of infection without radiographic infiltrate. So to differentiate between VAT and VAP is important. So ventilator-associated tracheobronchitis without infiltrates, and VAP with infiltrates and infectious signs. So that is basically the definition of most of the associations like IDSA, the European Society, all has like pneumonia after 48 hours of mechanical ventilation. Whatever happens after 48 hours, that is called as ventilator-associated pneumonia. Uh, so why are we discussing about VAP? Why is it important? Because the incidence of VAP is around 2 to 16 per 1,000 ventilator days. And usually the risk are during the initial 5 days, and then the risk slowly goes down to 2% from day 5 to 10, and 1% per day for the remaining days. Uh, so the question is, why is it important? Because it increases the duration of hospitalization and healthcare cost, and it increase the duration of mechanical ventilation, ICU stay, and all this takes it all on related to financial burden, and there is a lot of morbidity and mortality associated with. So how is the mortality? The most recent studies reported an attributable mortality of 10%. So that is all other causes of mortality taken away. There is an attributable mortality of 10% due to VAP, which is very, very significant. If you see the ICU VAP rates, this is just to show that there is more of VAP in neurosurgical patients. Neurosurgical, those patients who have got more of decreased level of consciousness, they are more likely to have a ventilator-associated pneumonia. So seeing some Indian data, there is more, if you see, the highest incidence is in patients with trauma, with history of trauma, and patients with respiratory issues like COPD, respiratory failure. All those patients have more incidence of ventilator-associated pneumonia. So what is the pathogenesis? The common sources of VAP pathogens, basically aspiration, the procedure of intubation. There is biofilm formation outside and inside of the endotracheal tube, which acts as a mechanical scaffold for the microorganisms, which protect the microorganisms from the antimicrobial agents, as well as it gets in through the host defense mechanisms. And there are contaminated secretions, contaminated respiratory equipments, all are sources of VAP pathogens. So this is an electron microscopic image of a biofilm. You can see the microorganisms protected by a mechanical scaffold, and this is a usual image, that is the endotracheal tube. Upon extubation, you can see a lot of secretions inside. You can see a thick layer of mucus and debris inside. So oropharyngeal cavity is primarily and the stomach secondarily is the most common source, and it becomes colonized by endogenous flora as well as exogenous bacteria, and that is usually given by the ICU from the ICU environment, from by the healthcare workers, and for acquiring MDR, usually the local ICU ecology is the most important thing. So we'll see how these exogenous sources work at the hands of healthcare workers. So we can prevent it by hand washing. So improper or uh, if we don't do a hand washing, that our hands can be a source for microorganisms. Ventilator circuits are again a source, and the biofilms inside the endotracheal tube is source of microorganisms. So this is an endotracheal tube. You can see the endotracheal tube cuff, which will not fit in very snugly, but uh, it'll be just with, so there'll be some gap between the cuff here, and hence the subglottic secretions which pool on top of the cuff will slowly sneak into through these gaps and get into the lungs and cause infections. So again, the biofilms as well as the subglottic secretions are the source for ventilator-associated pneumonia. Microaspirations and macroaspirations both play a role. And we know that endotracheal cuff prevents gross aspiration, but these microscopic aspirations cannot be prevented. The risk factors include, as I already told, underlying chronic disease, age more than 70, depressed level of consciousness, aspiration, elevated gastric pH, and previous antibiotic exposure is another important thing which leads on to the VAP. So to diagnose VAP, we need clinical signs and symptoms like fever, lab parameters like leukocytosis and leukopenia, then purulence, sputum, new or worsening cough, dyspnea, worsening gas exchange, uh, with radiological features of progressive chest infiltrates or consolidation, and microbiological evidence of any bacteria. So these are all the requirements for VAP. And why there are challenges in diagnosis, because there are lots of things which can cause this infiltrate, fever, leukocytosis, that can be non-infectious causes, that can be reactive airway diseases, tracheobronchitis. All this can mimic VAP. So it's definitely a challenge for diagnosis. So there are certain things which can give clues for VAP. And one of the earliest thing used is CPIS score. We know that there is a clinical pulmonary infection score which takes into account temperature, leukocytes in blood, tracheal secretions, radiographic findings, culture results, and oxygenation status. And these 6 parameters, we have a score of 0, 1, 2. And if the score is more than 6, it is not diagnosed. You have a high suspicion for VAP. There are few surveillance definitions which we need to know, because now CDC, because there was once the VAP bundles and all were issued, there was decrease in VAP incidence, and some hospitals here have even reported 0 VAP. So to get this reporting proper, they have now made something called as ventilator associated condition. So we'll see what is a VAC. It's called as a VAC. That is basically an increase in FiO2 or PEEP. So there is a worsening oxygenation which requires an increase in FiO2 or PEEP after 48 hours or more than 2 days of stable or decreasing PEEP and FiO2. As we know, once ventilated, it's like an ascent of an airplane. So at a certain level, usually within 48 hours, we kind of get into a stable FiO2 and PEEP. So once we get that stable FiO2 and PEEP, then when there is an steady increase in FiO2 by more than 0.2, or a PEEP increase of more than 3, so that is when they call it a ventilator-associated condition. So when you have a ventilator-associated condition associated with a fever, leukocytosis, or an addition of a new antimicrobial, then that becomes an infection-related VAC. So IVAC and VAC, and this once it is confirmed with a purulent secretion and positive culture, that becomes a VAP. So this is basically a surveillance definition which has been used by the CDC so that we don't miss any kind of VAP. So once we have a suspicion for VAP, we need to have a microbiological diagnosis. So this is from the IDSA guidelines, which was published in 2016. That's what we have till now. So what they recommend is basically a non-invasive sampling with semi-quantitative cultures. So we have invasive sampling like bronchoscopic bronchoalveolar lavage using a bronchoscope. We have protected specimen brush (PSB), and we can use a quantitative culture. But the IDSA has recommended a non-invasive sampling with semi-quantitative cultures to diagnose VAP, keeping in mind the high cost and the requirement for a uh, the requirement for expertise. So non-invasive sampling with semi-quantitative cultures is recommended, but we can always go for an invasive sample, which can be more specific with quantitative cultures. So we know the quantitative cultures for a PSB, the cutoff is 10 to the power of 3 colony forming units. For a bar, it is 10 to the power of 4, and endotracheal aspirate is the least. Uh, and it has got a threshold of 10 to the power of 10 to colony forming units. If you see what are the most common organisms causing VAP, as we know, in India, it is more of gram-negative bacteria, most commonly Acinetobacter, Klebsiella, Pseudomonas species, and most of them are multi-drug resistant organisms. If you see the global scenario, it is gram-negative organisms plus the gram-positive cocci, that is predominantly Staph aureus, mostly MRSA. So these are, that's the global difference. Like in India, it's more of gram-negative bacilli. In Asian countries, it is more of gram-negative bacilli. And in Western, we have more gram-positives as well as gram-negative bacilli. And we have to identify the risk factors for MDR pathogens. So age more than 60 years, mechanical ventilation more than 7 days, prior antibiotic use within 90 days, severe septic shock at the time of VAP, and ARDS preceding VAP, and renal replacement therapy prior to VAP, and systemic corticosteroids. So all this can are risk factors for VAP due to multi-drug resistant pathogens. So how do we use biomarkers and the CPI score to diagnose? So to diagnose VAP, it is more of clinical. So I have discussed the clinical criteria. It is more of the clinical criteria alone. So we have a lot of biomarkers like procalcitonin, C-reactive protein, bowel fluid, estrum, and we have clinical scoring with CPIS. So all these clinical criteria, that is the fever, hypoxia, leukocytosis, all these things helps to decide whether or not to initiate antibiotic therapy rather than using procalcitonin or CRP. That is to initiate antibiotic therapy. And ventilator-associated rectal bronchitis, that is without a radiological infiltrate, the IDSA has recommended not to provide antibiotic therapy. So the initial treatment. So once we have a VAP, how do we treat? How do we start the antibiotic? So it depends on the local ICU antibiogram. So as I've told, the local ICU ecology decides what kind of organism is going to cause the VAP. So definitely the ICU antibiogram plays a role, and usually it has a coverage for Staph aureus, Pseudomonas aeruginosa, and other gram-negative bacilli as well. In India, I think it's debatable for Staph aureus. If you don't have much of a Staph aureus, we can start on a gram-negative cover. If you have an MRSA, high MRSA incidence, you can go for a vancomycin or linezolid along with the gram-negative bacilli. And MSSA, we have specific oxacillin, nafcillin, or cefazolin. And once we start an antibiotic, we have to optimize the PK/PD, that is the pharmacokinetic and pharmacodynamics of the antibiotics. Specifically speaking, if you are using a time-dependent antibiotic like piperacillin, tazobactam, or the carbapenems, it is always advised to use an extended and continuous infusion, like for 3 hours, 3 to 4 hours. So the infusion has to be on, and extended and continuous infusions and weight-based dosing has to be given. And regarding the role of inhaled antibiotics, so once you start antibiotics, you can have an add-on as an inhaled antibiotic. That is predominantly in the case of gram-negative bacilli, usually carbapenem-resistant organisms, which will be susceptible only to aminoglycosides or polymyxins. And in those cases, you can add both inhaled and systemic antibiotics. So that is the recommendation. And regarding the pathogen-sensitive therapy, Pseudomonas aeruginosa, usually we always go for a dual cover. but it's not recommended if there is no septic shock or if there is no high risk for that. So if there is septic shock, always it is better to go for a dual therapy, and if it's not there, the monotherapy is recommended. And VAP caused by Acinetobacter, a carbapenem might be required. So uh, if it is, and nowadays we know most of the Acinetobacter we see in the ICU are even carbapenem resistant. So CREs and carbapenem resistant Acinetobacter, we have to we'll have to give uh, uh, colistin. And there are questions if we have a lot of carbapenem resistance seen, we can even give upfront colistin in such scenarios. So colistin and even colistin resistance is another thing which at times we come across. So once we start the antibiotic regarding the length of therapy, usually the recommendation is around a 7-day course. And it's not a fixed duration that is being recommended. It is based on the clinical scenario, as well as we can use the biomarker that's the procalcitonin. We can use uh, procalcitonin along with the clinical criteria to guide the discontinuation. So the antibiotic de-escalation can be done using the clinical criteria if the patient is improving and if there is a decreasing procalcitonin level. So you can repeat it in 3 to 4 days, and if you see more than 80, like if it goes below below 80% of the previous procalcitonin, that is also that will also be helpful in to decrease the to de-escalate the antibiotic. Second. Excuse me. Yeah, I missed a few slides. So that is the length of therapy. And as we know, we have there is something called as early VAP and late onset VAP. The early VAP is within 4 days, that is 96 hours of mechanical ventilation, and late onset is more than 5 days. And the importance is there is a possibility of a multi-drug resistant bacteria, MDR bug in case of late onset VAP. And usually 90% of in a European study, it was found that all VAP episodes occur within the first 10 days of mechanical ventilation, and late onset VAP account for more than half of the cases. So if you see the antibiotic preference early VAP, you can even start with Moxla, which is very highly unlikely if you are in India, because we might have to depend on the local antibiogram, and definitely there will be a MDR risk factor. So mostly we'll have to start with a piperacillin, tazobactam, or a carbapenem. And if there is an MRSA colonization, vancomycin or linezolid, the choices between them can be made based on the renal function or the blood counts. And there are certain, mostly we decide based on that. And there is no, even though vancomycin is bactericidal and linezolid bacteriostatic, it has been found that in the lung, it's almost equivalent. Most of the studies have shown there is no randomized control trial, but most of the studies have shown equivalent. It's less, none of them is, it's not inferior. Linezolid is non-inferior. And if there is a known colonization with a carbapenem-resistant Enterobacteriaceae or Pseudomonas aeruginosa, so we'll have to use polymyxins, colistin, and we have a new option called ceftazidime avibactam, which is being used currently, which has a place between the carbapenem and the colistin, so that we can preserve the colistin. Usually the Acinetobacter is not sensitive. If you have Pseudomonas or Klebsiella, it will be usually you can see the sensitivity for ceftazidime avibactam, and it's a very good alternative. The other options are not available now. So if we have a clinical suspicion of VAP, we can do an endotracheal aspirate or a bronchoalveolar lavage. So uh, there are plus positive and negatives for both. One is cheap and easily tolerated, but it is less specific, and there will be more of antibiotic use if you use an endotracheal aspirate. If you use a bronchoalveolar lavage, it is very specific, less antibiotics, large sample, but the cost is high, the special skill requirement, and the tolerance of the patient is negative. So we can either do, and if you see the guideline, you can always go for a semi-quantitative culture. But and there are certain Indian studies, which are studies from AIMS, which showed that a non-bronchoscopic BAL is equivalent to this bronchoalveolar lavage. So that would be an option. Like what we do in our ICU is we use mini BAL, and we do a quantitative culture. So once we have an infection, we start on empirical antibiotic treatment that is based on the local antibiogram, and we consider stopping antibiotics if the culture is negative. And if once we start on definitive antibiotic treatment, we can stop it at 7 days, and we can use procalcitonin in guided therapy as well. For the microbiologic sampling, we know it takes around 48 to 72 hours for a definitive targeted treatment as per the present. Uh, uh, we know microscopic and culture takes around 48 to 72 hours. But if you have a specific targeted PCR like MALDI-TOF, stream of flight, mass spectrophotometry, you can cut short that into 24 to 36 hours. Once there is a flag, there is a culture positivity, we can easily get the sensitivity pattern, and we can do that. And there is another thing called as multiplex PCR. There are certain lower respiratory panels with microarray analysis, which can give results in less than 6 hours. So that is what we are looking at, so that we can have a definitive targeted treatment in 6 hours. So that can save a lot of time. So as we know, VAP is more of a it's more of a quality indicator as well for considering an ICU. VAP is a qualitative indicator, and it shows how good our infection control practices are. So it's not just the VAP number shows how good the ICU is. So preventing VAP is the most important thing as far as an ICU is concerned. And we have to see what are the preventive measures what we can use to control VAP. And it is always VAP is always for VAP. I think prevention is better than cure, as the proverb says. So there are certain general measures. Then we can reduce the colonization of the aerodigestive tract, like selective oral decontamination, selective digestive decontamination, antibiotic-coated endotracheal tube. To prevent aspiration, we can change the positioning. We can use the subglottic suction drainage, ultra-thin cuff endotracheal tube, and obviously limit the duration of mechanical ventilation with sedation interruptions and early tracheostomy, which is doubtful thing actually. Regarding the general measures and prevention, we can have a universal infection control measure. We can have a hand hygiene, which should be around nearly 100%, and minimize reintubation, which is another quality indicator. And you can use a heat moisture exchanger, and you can avoid frequent circuit changes, because every time you change circuit, there is a possibility of contamination and pushing an infection in. And the drain condensate from the circuit has to be it should not collect, and it should not be collected. And adequate staff-patient ratio, which is I think easier in the corporate sector rather than in state-run institutes, where in corporates usually we have an adequate staff-patient ratio of 1:1 for ventilated patients. So 5 interventions which can prevent this semi-recumbent position. Stress ulcer prophylaxis. The association is not that's known because it decreases the DVT prophylaxis. The association is not yet clearly known. Adjustment of sedation. You have to give sedation vacations, and daily assessment of extubation, so that we extubate the patient early, the less chances of VAP. So this was tested in 112 ICUs. That there was a VAP rate of decline from 5.5 to a median of 0 cases at 16 to 18 months. So these are certain interventions, and we know VAP. We have heard of VAP bundles. The practices include hand hygiene, glove and gown compliance, elevation of the head end of the bed to 30 to 45 degree, oral care with chlorhexidine, maintaining an ET cuff pressure of more than 20 and somewhere between 20 to 30, orogastric rather than nasogastric feeding tubes, avoid gastric overdistension, and eliminating non-essential tracheal suctioning. And we can even use a closed suction, but the studies have shown that there is not much of mortality benefit, and the VAP incidents are also kind of similar. Uh, so with these 8 practices, rate of VAP decreased from 23 to 13 per 1,000 ventilator days. And there was no difference in total duration of mechanical ventilation or the ICU and hospital mortality. So if you see the non-pharmacological categories, again, it's daily sedation vacation, semi-recumbent position of more than 30 degree, endotracheal tubes with subglottic suction secretion drainage, and continuous controlled ETT cuff pressure. All this have shown to have resulted in reduction in VAP. Among the pharmacological categories, alcohol-based hand hygiene, oropharyngeal decontamination with chlorhexidine, and selective oropharyngeal decontamination have been shown to reduce infection VAP rates. So this is again almost the same thing, but we can see probiotics. So this is called as a gut-lung axis, and this is how probiotics are supposed to. These are postulated. It causes a lot of anti-inflammatory, and it preserves. It reduces the bacterial translocation. So probiotics also has got a role in preventing VAP. Uh, so head and elevation, again, I told the same 30 to 45 degree decreases the risk of aspiration, improve patient's ventilation and minimize atelectasis, sedation interruption. The weaning becomes easier, so less time on ventilator. Ulcer prophylaxis, it has got risk and benefits. Risk is basically the increased bacterial growth in stomach because of rise in pH, and endobronchial colonization and pneumonia. Prevents GI bleed because stress ulcer is usually quite common in intubated patients. So GI bleed and it prevents reflux, but this risk and benefit has to be balanced. DVT prophylaxis, the direct association is quite unclear. And regarding the oral care, dental plaque biofilms are usually colonized by respiratory pathogens, and it can act as a reservoir for potential VAP bugs. And comprehensive oral care with chlorhexidine is recommended. Subglottic suctioning devices is another thing which can help. We know that there is a lot of secretions which collects above the cuff, and it slowly, we can see these things slowly gets into the trachea and the airways and causes infection. So once we get the subglottic suctioning devices, we can reduce. So there is a dorsal lumen to allow for suctioning. And yeah, this is how this thing works. So there is an opening for subglottic port just above the cuff, and with this suction, we can reduce the amount of secretions which pool above the cuff, and it has found to decrease the like VAP, like it has seemed to reduce the incidence of VAP, and hence duration of mechanical ventilation by 2 days, length of stay by 3 days, and delay in onset of pneumonia by 7 days. Another way is to do the cuff pressure monitoring to prevent microaspiration. So as I told, it is between 20 to 30 centimeter of water which has to be maintained. 60 would be too high, and there is an increased risk of risk. So this is a cuff pressure manometer, and you usually monitor it and record it. Usually we do it every change of shift. Preventing biofilm formation on the endotracheal tube is another thing. So there can be antiseptic coating on inner surface of endotracheal tube. Silver coated endotracheal tubes are being used nowadays. Then regarding selective digestive tract decontamination, it's controversial. We can give IV antibiotics as enteral suspensions and administered during first 4 days. Several meta-analyses showed significant reduction in the incidence of VAP, but there is a concern the change in bacterial ecology of ICU and increasing antibiotic response. So it is not much used. And regarding the positioning, there is head down position has been tried, lateral, rotating, and oscillating. So a lot of positioning has been tried. and this was called as the zero WAP, the gravity trial, in which they used lateral Trendelenburg position. And even though like they have proved some benefit, it was not significant, and hence it has not been recommended as a preventive measure. So there are a lot of things with positioning as well. And as I've told, we need a chest X-ray infiltrate for diagnosis of that. So it would have been easier if it was a CT-based approach, but it's not feasible considering the cost and moving the patient and the radiation exposure. So everything makes CT. CT is a better option compared to X-ray, but it's not feasible. So somewhere in between, with no radiations and easy in the ICU, lung ultrasound is something which may provide the diagnostic accuracy and being studied to know to differentiate just colonization from tracheitis and VAP. So lung ultrasound is coming a big way even in VAP. And the take-home messages would be the diagnosis of VAP and VAP is largely clinical radiological. So it is more of clinical radiological. Microbiology is essential to know the flora in the ICU. That is, the local antibiogram is a must to start to initiate antibiotics if you find a VAP. And it may help in de-escalation of antibiotics, and you can always use calcitonin as well. Risk factors for MDR pathogens must be recognized, and usually a combination of antibiotics might have to be used. And aerosolized antibiotics can be used along with antibiotics for gram-negative bugs like for which we might need colistin as well as aminoglycoside. We might have to use aerosolized antibiotics as well. And the knowledge of local microbiology is very much essential for treating VAP. So thank you. I think that was on ventilator-associated pneumonia.
Thank you, Dr. Amit. It was a very I mean, you have incorporated the latest aspects even of the prevention. So very thankful to your webinar. Thank you, viewers. Bye bye. Good night.